Good day, listeners, and welcome to Beyond the Checkbox, where you learn how to integrate more mental wellness into your organization. I'm your host, Dr. Ryan Todd, and we are here with a very special guest, Dr. Rahim Kachra, who is a clinical associate professor at the University of Calgary. He's a director of teaching innovation, and he is a specialist in internal medicine and very much on the front lines of the COVID experience. And thank you, Rahim, for joining us today.
Thanks for having me.
Or is it Dr. Kachra? How do you want to be addressed?
Either sir or professor. I'm just kidding. Call me Rahim, Ryan.
Professor, sir. Well, I think we have a lot to learn today because we often talk about poise and focus and preparation, and you are putting all these skills to work in a very real crisis. The other thing we talk about in the workplace is crisis, but this is actually a crisis. And I more or less wanted to check in with you first and see how you're doing throughout all this and what this experience has been like for you.
It's been interesting, to say the least. I'm a part of a group of 30-something physicians in the Department of Medicine in Calgary, where we're looking at planning for what we know is coming, for the influx in patients admitted to the hospital, for the increase in the death rates of our population, for the deaths of our colleagues, for the social isolation from our friends and families as we embark upon going into the hospital, into the quote hot zones, and going through that whole process. So it's been interesting. One of my colleagues had mentioned to me the other day that everyone should get their heart rate above 120 and below 60 every day. I think most of us are doing really well at staying above 120, but it's getting below the 60 part that gets a bit challenging at times. But, oddly, a sense of purpose really helps you through these situations and keeps you amped up and ready to go. We just need a downtime at some point, and I look forward to that when all of this is over.
You mentioned you're in a hot zone. Can you help contextualize your job a little more for our listeners? Like what are you doing on a day-to-day basis? What is a hot zone? Give us a little more background about your day-to-day and then how that's changed with COVID.
Sure. Yeah. So I think the first comment I'll make is the day-to-day, as someone smart once said to me, his name may or may not have been Ryan Todd, it's a run-on sentence. Weekends, evenings, overnight periods, they've all kind of lost their meaning. So when I think about what I'm doing, there's a couple of rules. So number one, I am a general internist. That is what I'm trained to do. I'm trained to take care of complicated, sick patients who come into the hospital. And so one part of it is taking care of patients with COVID-19 who are admitted to the hospital setting. The second part of that is I am the officer for MD training within the Department of Medicine. So if you think about the number of physicians we're going to need to care for the number of patients that we're expecting, it's astronomical. And so part of my role is to make sure all of the incoming physicians into the inpatient setting are trained and ready to go when they approach these zones where we're going to be keeping COVID patients. So when I say hot zone, it's kind of a term that I think it was Richard Preston wrote a book back in the 90s that kind of popularized that term. But essentially, what we're looking at is an area where we can co-locate patients who test positive for COVID-19 so we can minimize the spread of the disease around the hospital, so we can keep patients all in one area, we can keep providers all in one area, and we can have strict infection prevention and control mechanisms in place in that space.
What are you doing now for preparation? Like, I want to talk about the logistical side, and then I want to talk about the psychological side of things, and tie that into training a little bit. Logistically, what is being done and prepared for? Because, you're the officer for MD training right now. You're on the front lines of this thing. What is the hospital doing to anticipate this surge?
Yeah, good question. And I don't even think I can boil it down to one thing. The number of different subgroups we have kind of blows my mind. And we have some excellent leadership who has really taken over sorting out what the key areas are and who the right people are to be in those roles. So we look at things like processes. when patients come into the door, they go through the emergency department. How do they get to our service? How do they get to the unit they're supposed to get to? Who are they going to call for advice? Who's going to be the physician that admits them? What's the role of medical trainees in all of this? We have the side of MD health and wellness, where we're looking at how are people coping through all of this. As I mentioned earlier, we're kind of the mindset to expect that our colleagues might pass away from this disease. And so, not just colleagues, but patients, families, even members of our community, we're trying to get ready for the mental preparation that's involved with all of this. And we have some great resources and supports in place for that. We have the group looking at how can we use our electronic medical records better to support all of us through this process as we get ready for an influx of a large number of patients on a daily basis. As I mentioned, my role in collaboration with the fantastic team that I'm working with is looking at how can we train up a lot of physicians on things like how do you appropriately put on and take off your personal protective equipment? How do you get trained on the EMR so you're ready to go? Is there a toolbox of resources you may need on a day-to-day basis and the like? So there's a lot going on, and there's probably 6 or 7 other groups that have carved out niche areas that are looking at relationships between providers and how the flow works from that perspective, et cetera.
Have you experienced anything like this? Has anyone on your team ever experienced anything like this?
No, I think in Calgary we've been lucky. We haven't had any of the recent major outbreaks that we've seen, like the Middle Eastern Respiratory Syndrome or SARS, which in Canada, the main cities impacted were Toronto and Vancouver.
So there's really, there's no protocol here. There's no playbook. And it appears to be all critical thinking, kind of on the fly and putting plans together as you go. Do I have that right?
Absolutely. And we're learning a lot from our colleagues across the world who've gone through this already. I have a mentor who works in Singapore, and I sent him an email to check in, and he replied, with some very interesting information on how his group is dealing in Singapore, because they're a few weeks to months ahead of where we are right now, and just to see what it looks like after the fact, where they're talking about cabin fever and talking about maintaining some sort of a emotional investment still after 2 months where they're exhausted, but still have to provide that care.
And that's the part that I wonder, like, if this was in the 1918, this is the Spanish flu or whatever. I'm obviously not an epidemiologist. And I wonder if we'd be talking about the psychological aspect. And now that people are more literate in terms of mental health and anti-stigma and their own psychological health, there's been so much conversation around how do we take care of ourselves mentally. I find that very fascinating. And I wonder how your physician group, how you yourself are handling the anticipation of this all.
So I think the scary part is the anticipation, and there's a term that's been floating out there that I think has been adopted from previous military literature called pre-TSD. Dr. Alison Block, she's a family doctor in the Bay Area, in mid-March published an article in the Washington Post where she talked about how we're all feeling psychological ramifications of the trauma, but we haven't experienced the trauma yet. And I think that it hits the nail on the head. We're terrified about what's coming. We can't do anything about it, but we have to get focused and prepare for it.
I do want to ask you about the purpose of all this, because I think that people have found a new level of purpose in helping their colleagues, in helping a lot of sick people. You have a life where you have a lot of meaning and a lot of purpose because you take care of sick people all the time, and you're obviously driven by that. But talk a little bit about this new level of purpose and meaning that you have and your colleagues have with helping with a pandemic.
Yeah, I think it's a very humbling position to be in right now. I don't think anyone wants to be in this position. I don't think anyone wants this exact sense of purpose. But that being said, it's our job. It's what we all signed up for, and it's what we all are trained to do. So when it comes down to it, that sense of purpose is there, but it's kind of I don't even think about it, if that makes sense. Right now, my goal is to train MDs. My goal is to train myself. And my goal is to take good care of patients. And part of that means taking good care of myself. There's been a lot of chatter amongst our group where we talk about not going out, not going grocery shopping. I was meant to go home and visit my parents in Edmonton last weekend, and I didn't go, partially because of the risk to my parents, but also because if one of us goes down, that's one less person to fill a call schedule for 2 weeks. So that sense of purpose, I think, extends beyond just your work in the hospital. I think it's even more physically isolating. I think there was a 14-day stretch when I didn't leave home, not because I had symptoms, not because that I was meant to be in self-isolation, but because I was scared to take that risk of going down and not being able to fulfill my purpose as a MD training officer or as a physician on the ground taking care of patients.
There's also this really interesting, and kind of there's been a couple of really sad reports about doctors who they're self-isolated, but in two places. One, hospital, where they're dealing with chaos and a lot of really sick people. And then two, they go home by themselves and they're isolated from their family. How are you experiencing that dual self-isolation kind of experience?
I think it's interesting where I think it was Dr. Teresa Tam who first said it, that we shouldn't be socially isolating, we should be physically isolating. And I think that has created a unique spin on this situation. I've heard stories of people becoming less socially isolated while they increase their physical distance, because it allows them to reconnect with people. They're spending more time on FaceTime or Zoom or Skype or whatever mechanism of keeping connected with people. They have more time because they're home, so less travel time, etc., where they can spend the time face-to-face interactions, albeit over an internet connection. And so I think it's interesting for me personally. It's not that much of a departure from my real life, as sad as that is to say. I commit my days to being in my office. I have roles in education, I have roles in research, I have roles in administration, and I spend a lot of my time working and very little time outside of that doing anything for myself. So probably not the thing you want to say to a psychiatrist on a podcast, but it's not that much of a departure for me. That being said, I have a lot of colleagues who have families, pets, etc. at home, and they're feeling the stress of this. They're feeling the strain on their own personal dynamics. But so far, not a lot of people are isolating at home from their families unless they're symptomatic. We've come up with some interesting routines that we've adapted from Twitter, from colleagues across the world, where we have a decontamination procedure. So we're making sure we're trying to minimize the spread of disease within our own households.
And what are your colleagues saying? Because you're training, are you training other internists, or are you training other specialties to come and backfill roles when internists maybe get sick?
Yeah, so we're training people who are not specialists in general internal medicine. So we're looking at physicians from respirology, nephrology, rheumatology, endocrinology, oncologists, etc. So others to learn how to function safely within our environment, which is what internists would typically function in.
How has that been? Has it been a challenge to bring other physicians who, I mean, a lot of them, like your respirologists, you probably haven't done general internal medicine in some 20 years. How has that challenge been in bringing on new people, training on new people for the crisis?
I think the challenge has been interesting. I look at it a lot like I'm kind of a design thinking nerd, I like the concepts of rapid iteration, starting early, getting a sense of what your user needs before proceeding to define the problem. And I think that's where we've been lucky. Our leadership identified what's coming early. So we've had opportunities to get people into shadowing positions to see what issues they need to sort out before getting onto the wards and being independent. And so we've been very, very iterative in our process. I think, I kind of enjoy that challenge. I try to kind of be insular about it, to say, hey, this is my challenge of MD training, and try not to think about all of the other aspects that can be involved in it from a COVID perspective, and to just think about how can I train 250 to 500 physicians to be ready to go. I've been lucky, like I said earlier, to have a fantastic team that I get to work with on this process, and everyone has a different area of expertise. And so together we're able to come up with things and be responsive rapidly to changes we need to make.
Your training and education. I mean, you have a master's from Harvard, no big deal. Your training and education is really coming to the forefront now. Did you imagine that that would happen?
No, not at all. You know, I have a couple of roles within medical education at the University of Calgary, but I never thought it would be ramped up to this level ever. This is beyond my wildest dreams.
And what type of skills and tools are you bringing from that educator background and that innovation teaching background that have been helpful to help train a mass amount of physicians to deal with this crisis?
I think the biggest thing is framing of the problem. A lot of the times in medicine, and you can correct me if I'm wrong, but we're guilty of thinking we already know what the problem is, and we're guilty of thinking that we already know what the solution is. I think that was probably one of my biggest take-home messages from my time in my master's, was that sometimes we're not the all-knowing. We don't know what the problem is, and to have a hypothesis, invest a lot of money into solving it, and then to find out you were wrong is probably not the right way to go about it. My approach has always been, let's first make sure we know what the problem areas are, and then let's start with small solutions and scale them up and keep iterating and keep improving, even once we think we have the ideal solution, because we'll never have the ideal solution, and we'll have to keep changing and keep adapting to whatever's going on.
If it's okay, I want to dig into that because I think our listeners will really benefit from hearing how, a physician on the front lines with an education background is solving a problem. And so you mentioned that you first identify problem areas, then you have small iterations that you kind of deal with. Can you take me through the first step of this crisis in training physicians? When I see the problem, it's like, okay, there's a virus coming that is a potentially deadly virus for a large group of individuals. That's the problem. How are you seeing the problem, and how is your group thinking about it? How are you taking people through that methodology?
So the way I started this process was first trying to spend time with the person who's going to be on the unit that may not have been on the ward in 20 years, that may have a non-acute care background, that may have just graduated from their residencies and fellowships, but has only been a year or two out, so may have a different level of understanding. I think the group of people we're looking at is so heterogeneous, it's challenging to design a one-size-fits-all solution. But step one is to spend time with those groups and understand what their problems and issues would be going into this space. After doing that, we came up with a buddy system model where we threw some of these physicians into the area that they'd be working on, but we paired them up with a general internist so they would have full support at all times. After they completed a 3-day buddy shift, essentially, I spent some more time with them, and we went through the process of getting into the details. What made you anxious about the time you spent on the unit? Where do you think your training gaps were? We already had a little bit of education up and ready for them before they started. So we also got some feedback into that. Were the resources we provided adequate? Where could we have improved? What was a big blind spot for you going in? Are there any critical errors you would have noticed? And so we took a lot of this feedback and then tried to spin that into solutions. So like I said, we started with a small solution, which was an educational toolbox. We had a website with all of the pieces of information we thought somebody would need. As we've gone through the process, that website went from this much information to this much information, because we realized the link burden and the overwhelming amount of information we were providing to these physicians was actually not helping them, or we needed to boil it down to, this is what you absolutely need to know. We had to reduce the cognitive load on these physicians and try to have them ready with what they exactly needed to know. We also found some interesting comments that they felt very well supported, and they liked the idea of having an expert in general internal medicine whenever they needed one. And we also found that there are certain groups like respirologists and nephrologists who are used to dealing with more acute care, who may not need to have a general internist around as frequently as other groups may. So it's been a really interesting process. One gap we wouldn't have actually picked up until we did the training process was the use of the electronic medical records. Some of the physicians who work more as an outpatient and less as an inpatient don't use the EMR in the same way that we would. And so we've had to now create a huge training session for how to appropriately use the EMR within the setting that we're anticipating.
Technology's played a huge role in this.
Absolutely.
And a lot of leaders right now are trying to use technology to their best of their ability, but also it's tough for people to adapt to new technologies so quickly. Um, Tell us a little bit more about how integral technology has been, in particular just websites, but it also sounds like the tech is not that complicated. How have you been able to use technology to your advantage and not let it get in the way?
Yeah, that's a great question. I think, well, let's look at what we're doing right now. We're doing this over Zoom, right? 3 weeks ago, you would have done this in person with that fancy brick background and a nice view of what looks to be just outside of downtown Calgary. Am I
It
wrong?
is.
Oh, there
Yeah.
you go.
Yeah.
There you go. So, I think there's a huge role for technology. One of my other roles is in medical education as the director of teaching innovation, looking at how we teach and how we can improve the way that we teach. We've recently put out a survey to medical students and residents all over the world, looking at how their education has been impacted by the switch from in-classroom, in-person sessions to everything being online and virtual, essentially. And so I think there's a lot of places we can pull from to guide what we're doing right now. And so we're looking at literature from SARS and MERS and Hurricane Katrina and other natural disasters to guide us on how we can best use technology. And like you said, I don't think technology has actually been, adapting to technology has not been a hard part about this. Zoom is something we use a lot of, and training people on Zoom takes 15 or 20 minutes max, and you have someone who's ready to go with the baseline information that they need. Similarly, we're putting a lot of our stuff onto websites, but we're also being sure to create discrete modules, which we have a lot of support for in Calgary. So users don't have to figure out how to use the technology, but rather they can just focus on the content within the technology. Once you make the use of the technology more complicated, you're adding an extra step for people to try to sort through, and that's a barrier. So the big thing we're trying to do is use technology as a tool rather than as something that's a necessity to enable use of that tool, if that makes sense. So if we have to get someone to learn a technological tool first and then create the educational module, then we've messed up. Right now, we're adding an extra step and an extra barrier to getting to the educational module. So what we're trying to do is make the technology just part of the background, so it's not complicated, it's not challenging. So then the focus can be on the educational module rather than the technology.
The simplicity of it, or the striving to make it simple, is like really striking here. Without it, this whole thing falls apart.
Yeah, we've had our struggles. Don't get me wrong, but we're learning from them. Getting someone to sign up for a website or log into a website is a hurdle, right? My website didn't work. The verification email went to my junk mail. I don't know how to access my quarantine folder, and so there's a lot of areas where we've run into trouble. But just by simplifying things or adding it to a site that users are already familiar with, takes out that whole barrier from the picture.
In such a technology driven, like the necessity for technology, how have you, as the lead trainer, how have you integrated mental wellness, psychological health? Like for you, where does that lie? It's obviously been very important for you. How have you been able to integrate that despite it being such a technology heavy play? And the reason I ask it like that is because a lot of people associate technology as being a cold, dry, robotic way of communicating, but you are marrying these two worlds of needing to use simple, user interface friendly technology and really take care of the emotional health of your trainees. How have you been able to marry those two worlds?
Yeah, I don't think I'm doing a good enough job. Part of it is we have a committee that's focused on wellness, resilience, and part of me is like, okay, when they're ready, we'll deliver. But I also think we do things on a day-to-day basis that hopefully help people. When we have Zoom meetings, we're getting better at just automatically turning on everyone's camera so we can at least have some face-to-face interaction. There was a day last week where I had 13 hours consecutive of online virtual meetings, and my camera was on for a full 13 hours, and it felt good. right? It was nice to see faces. It's not the same as seeing them in person, but it's better than just talking to a blank screen all the time. I also think the reliance on email, therefore, has gone down as we try to solve a lot of our problems in a more face-to-face environment, or screen-to-screen environment, I guess. And that's just the little things that we're doing. Can we do more? Absolutely. Where I struggle personally, and it's a good thing I'm talking to a psychiatrist right now, is when we think about, what more can we do, and is what we're doing enough? So there are a lot of groups out there that are offering a ton of support, but the barrier I see is I have to call them. I have to contact them to get that support. And for me, that's a barrier. I mean, you can't force wellness upon anybody. You can't force someone to get help if they need it. But I think sometimes people are unable to identify that they need that help. And that's step one. And then step two is they need to identify it and then reach out to someone. And as we talked about technology earlier, sometimes being a barrier, like extra steps to get to the educational module would be a barrier. I kind of see that on this side of things as well, that the fact that I have to pick up a phone or send an email to get help is a barrier for me if and when I need that.
And physicians are, I would say, notorious for being a tough group to reach because, I mean, in some ways they're supposed to have the answers. There is still stigma around that. Are you seeing some of that difficulty in reaching out with your physician group, with yourself? Is it a technology thing? What's going on there, do you think?
I think there is a few things. Firstly, it's a shared experience that we're all going through. We joke about getting jolted awake at 3 or 5 in the morning every single night because something has stressed us out in our dreams that has to do with the current situation we're going through. We joke about not being able to get our heart rates below 120. We talk about not being able to get a good night of sleep, and I think it's probably been 3 weeks since I've had one. And we're all aware of these things. We're all aware of what we're going through. We're all aware of the PTSD. And we're also aware of all the resources that are available to us that we should be getting, and we should be seeking out at this time. But no one's doing it, me included.
And do you think that's because of technology, or why do you think that is?
I think it's part of it is this is part of the job. We should expect to feel this way. But I also think a part of it is, the 16 to 18 hour work days we're all putting in. There's no time to really think about yourself. I was reading an article this morning about a geriatrician in Toronto who's working till midnight every day, hasn't eaten, he's losing weight. And that's kind of the reality a lot of people are looking at. I think for me, it's the opposite. I don't know how I'm going to go this hour without snacking on something because I'm sitting in front of a screen all day. I always need to eat something to keep going. But I think that is a part of it is the time commitment that it requires. And, I've been counting my emails on a few days. I'm getting well over 200. To keep on top of that email burden, do I really have time to send one more that's going to benefit myself? No, I'd rather respond to 5 others that have gotten to my inbox in the time that I've just thought about emailing someone for help.
Wow. You're outlining, I think, just like such a powerful experience, and that's, it's very self-sacrificial. Is that a doctor thing? Like, do you, you're putting, not just, I don't want to say it too simply. Like, I mean, you're putting definitely others in the job before yourself. But it's almost, in a way, it sounds like it's disincentivized to reach out or something there. Tell me about that part of the doctor's psyche so people, and myself included, can understand what's going on there.
I don't think it's novel to what's happening right now or pandemic preparations. You always hear stories about physicians going to work with bowel obstructions or going to work from the emergency department with an IV in, but still reviewing patients and still making phone calls to patients. I don't know what it is. It's probably cultural in some aspects in that, the training it's grueling. You have, 26 plus hour shifts on a regular basis, and you're used to kind of just going for it and pushing through things. I think we're seeing a bit of a cultural shift right now, because if you have a sniffle, if you have a cough, 14 days, you're home, you're isolated. So it's kind of there's that hard stop now that didn't exist before. I've had shifts. When I was a resident working night float shifts, I would take Dayquil at night to get through my night shift, and then come home and take NyQuil because I was so sick and I wasn't able to sleep from a bad cold, right? And now we're seeing a shift to, okay, you're sick, you're not going to work, and that's being supported by everybody. But I think that you're sick is being focused on the physical manifestations of an illness rather than the psychological or mental manifestations of an illness that you could be feeling. So I think there's still that gap between, having a cold or having severe anxiety and not being able to function because you're so stressed out with what's to come.
That is really interesting, because I think physicians may be some of the most prominent vectors of this in the end, because we are trained, correct me if I'm wrong, in internal medicine is notorious for this. You're trained to hide your symptoms. You're trained to not complain. You're trained to power through. My wife is a resident, and she was bragging that she's only taken one sick day in her entire training, and she's been training for like 8 years. And that's a badge of pride for her. And I know it is amongst internists as well. And so there's been this shift in, like, if you have a little tiny symptom, that you're out for 2 weeks, which is like totally opposite of the culture and what you've been taught and everything. Is that part of the training? Are you training, like, you're training a huge group of physicians, you're the lead on this. Are you also training them to try and be more self-aware and reasonable when it comes to their health?
The funny thing is, I don't think that's something that's probably a blind spot that we've had, because the internal dialogue I'm having is that these are physicians. I shouldn't need to tell them to stay home if they're sick at a time like this, where you hear Dr. Hinshaw on the news every day saying, if you're sick, stay home. And I don't think anyone thinks they're above that, right? So I think physicians are aware of that they don't want to be the vector of disease. They don't want to be the person that comes into the hospital and spreads COVID to 23 patients that they've seen that day, right? I 100% agree with you. In the past, it was a badge of honor to show up and get through a week of inpatient service with whatever. I myself worked with a bowel obstruction when I was a first-year resident. And, retrospectively, that was dumb, right? The hospital would have functioned without me. Did I have that much of an ego that I thought that I needed to be there? And I think those are some of the things that are changing with the pandemic, and that might actually be a welcome cultural shift for our profession. That being said, I'm also the guy that brags that I only peed once a day, when I was on service, or didn't stop to eat lunch for a full day and maybe had one meal a day. So I think that needs to change.
And do you think it will? Because I think that when we're talking about mental wellness of physicians, of course, I think this, but I think we're at huge risk of losing physicians due to mental health issues. You've talked about pre-TSD. You talked about the anxiety of anticipation, the anxiety of potentially being a vector. I mean, like, you talking about other physicians anticipating that some of their colleagues may die because of this, because of the exposure they're getting at work. That's heavy. And I think that we're at risk of losing physicians due to mental health issues. And then I also think that physicians, among a whole host of other groups of frontline individuals, they don't want to recognize it. They don't want to talk about it. Have you seen a shift there, or where are we at with, like, doctors talking about their mental health during this crisis?
I think people are talking about it, but I don't think we're really thinking about it, if that makes sense. So it's commonplace to say what you're feeling or say what you're going through, but I'm not sure how seriously people are taking the experience from a mental health perspective, if that makes sense.
And do you think it's just physicians not allowing themselves to do that?
I think it's probably multifactorial, like everything in medicine. That's always my answer when I don't know what to say. It's multifactorial. But no, if you think about even if you think about what the public's perception is of physicians, right? I don't think people realize that we internalize a lot of what we see. And it's really hard to take that stuff home every day. And so if you see a really sad case of whatever in the hospital, you don't take that home with you. You don't talk to your family about it. You don't talk to your partner about it. It's not something you dive into. It's something you learn to internalize and put into a box. A lot of us feel that, who can you talk to that's going to understand what you're going through? And that's hard. I was talking to a colleague of mine who's an oncologist yesterday, and she was telling me a story about how she's sending a patient to hospice, and her biggest fear is that that patient's 11-year-old son won't get to see his mom before she dies because of the limitations on visitation, right? That's something you take home with you. That's something that you toil over, and it stresses you out because we feel those experiences with our patients. We empathize with them. And I think a lot of people don't realize that, but I also think physicians are so used to taking those experiences and those stories home and internalizing them and not talking about them, that their experiences throughout the pandemic are going to be very similar, right? Am I stressed out that I'm on nights starting tomorrow and I'm going to be taking care of COVID-19 patients? I don't know. I'm not really thinking about it yet, right? Will I come home and talk to my partner about that at the end of the day? Probably not, right? And so I think there is this big barrier to actually getting into the weeds and talking about how you're actually feeling at the end of all of this. Do I anticipate there's going to be a change in the workforce after this? Absolutely. People are holding on to the thought of being on a beach 6 months from now and just forgetting about medicine. A lot of my colleagues, nursing, allied health, physicians, have said that after this is all done, they might reevaluate what they're doing as a part of their work life and maybe take a break from the world of healthcare for a little bit. I think that's a real possibility. And I think it's probably a fair possibility. I think people may need to somehow decompress after all of this is over, especially because it's still not commonplace within the medical culture to appreciate the impact that these experiences are having on your mental well-being.
A lot of what you said there was really powerful, and I've had a similar experience where, in my line of work, and I remember one particular day when I saw 3 individuals who were under the age of 50 who were all had terminal diagnoses, metastatic cancer. So they were all 3 of them were going to potentially die within 6 months of me seeing them. And then I came home and my wife asked me, how was my day? And I said, yeah, it's fine. It's a normal day. Why did I do that? Like, I don't get that. Like, and why physicians do that. And I think this, I'm hoping this COVID experience, if it teaches us anything, it's to take care of ourselves first, because we are, you are on the front lines of things, and without you staying mentally and physically well, I don't know what we're going to do. So I hope there's a shift in the way that physicians and people in the workplace take care of themselves after this, because I think that the repercussions of not doing that are significant.
The first thing I'm going to do is get a haircut.
Your hair looks great. I don't know what you're complaining about. I have a couple more questions for you, Rahim. How are you taking care of yourself? You are doing 13 hours a day Zoom meetings. You are going on a night shift tomorrow, starting nights for a week or 2 weeks. What are you trying to do to stay well during this time?
I'll be honest with you, Dr. Todd. I started out by not doing anything. It was just anxiety-filled day after anxiety-filled day, but now I'm taking the time to exercise a little bit every single day. I found that I wasn't getting out of the house just because I was so busy. And as I mentioned earlier, I had a 14-day stretch where I never saw the daylight. So, part of it is trying to maintain some sort of a normal routine in my day. I wake up every morning, I go for a shower, I put on clothes as if I was going to work. And then, my exercise at the end of the day, I get out for a walk, I see the great outdoors with appropriate physical distancing. And kind of having some semblance of normality in my life is really the only thing I can do right now. I make sure I spend some time on FaceTime with my parents and my sister and niece and nephew and those sorts of things every day. But otherwise, the focus is on what's coming up. what I have to do, and I don't want to lose focus of that. And as important as it is to take care of yourself, this is contradictory to everything we've talked about. My priority isn't taking care of myself right now. My priority is staying focused on what's coming.
Well, Dr. Kachra, I want to thank you for joining us today. I think we learned a lot about not just focus and poise, of which you have a ton of, obviously, and leadership, but also taking care of ourselves. We also learned a lot about system level thinking and planning, what you're undertaking to train 250 physicians to take on crisis roles where they previously had not had roles is it's kind of a mind-blowing expedition that you're on, and the world is grateful that you're doing it. So thank you for coming on the show today and sharing your personal experience, what you've learned, and I know I've learned a lot today, so thank you.
Thank you, Dr. Todd.